this kind of invitation. Vascular access is a very important thing during TAVI procedure. As we know, transfemoral TAVI is the most commonly used approach. There is no need for surgical preparation. We can perform this procedure under local anesthesia. And in this session, we will highlight the importance of optimal vascular access and closure in TAVI patients. First of all, as we said, CT assessment gives us all the important information regarding vessel size and diameter, tortuosity of the vessel, common femoral artery and the iliac arteries, the degree and the location of calcification, and the bifurcation height. We have to examine each vessel, the right and the left side, separately in order to decide for the best access. And some possible problems could be the small diameter of the vessels, less than 5 millimeters, circular calcification, especially in the anterior wall of the vessel, and if we have a tortuosity plus calcification. How we can solve these problems? In case of a small diameter, less than 5 millimeters, we can proceed for a POBA, for a balloon angioplasty, or to use intravascular lithotripsy. If we have a severe tortuosity, we can handle this problem with stiffer guide wires like Landerquist or a backup Meyer. But if we have an extreme calcification, it's better to consider for a surgical repair or for another access. In order to make the perfect puncture, a good choice is to use either a fluoroscopy or a roadmap or an echo-guided puncture. Let's start with the echo-guided access. First of all, we have to distinguish the artery from the vein. Okay. By compression the probe, veins we know that are more compressible and pulseless vessels. We go down with the probe to determine the profunda and the superficial artery in order to locate the exact bifurcation of the common femoral artery. We turn the probe in the longitudinal view, as you can see down, and we search for the perfect target zone. And the perfect puncture should be at the superficial side of the vessel, and we have to avoid the zone that the vessel dives into the body. So let's see a video. We start in the longitudinal axis. We rotate the probe to the short axis view. Here we can see better the anterior wall of the artery. And just a small tip is to make the local anesthesia under fluoroscopy, under echo guidance, and to reach the adventitia of the artery, because in this way we have more effective anesthesia. The patient is more comfortable, especially if we use only under local anesthesia. And after local anesthesia, we go for the puncture in this view, in the short axis view. Another advice is to use the Pythagorean approach. We have to avoid to start our puncture too close to the probe and keep the same distance as the distance of the depth in the 45 degrees. If we use the fluoro, let's say that we start our puncture in the right side, we have to place a guide DIMA catheter in the contralateral artery. We advance a Grand Slam guide wire 3 meters or an Ironman. This is our safety guide wire, and it serves as a marker. And we make our puncture using this fluoro, targeting the mid-femoral head, and the marker, and we mark the guide wire that we have placed before. Our advice is to make all the puncture under echo, because using echo we have less vascular complications. To move on, closure devices. There are different ways to achieve hemostasis to the vessel. We use ProGlide or Manta in daily practice. And few words for these closure devices. ProGlide can close arteriotomies up to 21 French, but we have to use it in 2 steps. At the beginning of the procedure to make the pre-close technique, and at the end of the procedure to make the management of the sutures. This is a suture-based technique with the ProGlide. Otherwise, the Manta can close arteriotomies up to 22 French, and we use it at the end of the procedure. And it's a collagen-based device. Few words about the ProGlide. Step 1 is to open the foot into the vessel. Step 2, we bring down the needles. Step 3, we deploy the suture, and step 4, we close the foot and we bring back the device. Just a video, this is the beginning of our procedure. We pull back the guide wire, we keep the 45 degrees, and we advance the ProGlide. Is very simple, the technique. When the bleed, when we have back bleed, we rotate the lever, we pull back the device, we break down the suture, and we cut it, as you can see here. We close the foot inside the vessel and we bring back the device. Afterwards, we pull back and we take these two sutures ends. It is one suture with two sutures ends. We bring them together with a clamp, and we can continue with the second ProGlide. This technique is at the beginning of our procedure, and if we use a rotation of the ProGlide at 10 o'clock and at 2 o'clock, we end up with a crossed suture, as you can see in the right side of the picture. But our recommendation is to make a parallel suture technique. We don't have to rotate the ProGlides at the beginning, and with the parallel suture technique, we have less number of vascular complications. At the end of the procedure, we have to manage the sutures. As you can see, we recommend to do this with two operators. The one operator manages the suture, and the second operator pull back the large bore sheath. And using a device, the knot pusher, we push down the knot in order to close the arteriotomy, and we repeat this several times with the one suture and the other. We keep the guide wire for safety reasons at the first, and if hemostasis is achieved, we pull back the guide wire, we repeat this procedure, and we cut the suture, as you can see here. If ProGlide device fails, we have some steps to make. We can use an angioseal or a MANTA device. If this fails, we have to proceed with a balloon inflation and manual compression, or to use a cover stent and Armanda, or to go for a surgical repair. MANTA device is another technique, a collagen-based technique. It's very simple. We use the MANTA at the end of the procedure. We remove the large bore sheath. We introduce the MANTA sheath. We remove the introducer. We keep the guide wire always in place. It's like to use a big angioseal, and we proceed with the MANTA device. Here we listen the first click, and you can see that we pull back the whole device. We have calculated the deployment depth at the beginning, and we rotate the blue lever. And in this way, we release the anchor inside the vessel. We pull back. There is a green and white, green and yellow indicator, and pulling back the closure device, we release the collagen. And in this way, the arteriotomy is closed. And there is a tool that we advance it to lock the collagen in the outer wall of the vessel. If MANTA fails, we don't have many things to do. Bailout strategies is balloon inflation, manual compression, covered stent, or surgical repair. Choice closure study showed that MANTA was associated with higher rate of vascular complications such as hematoma, pseudoaneurysm, but we had a shorter time to hemostasis compared to ProGlide. ProGlide had many devices failures. And which technique is better, ProGlide or MANTA? At Eurointervention, a multi-close algorithm was published recently, which says that we have to start always with one ProGlide. At the end of our procedure, we remove the large bore introducer and we insert a 6 or 8 French sheath in order to make a small contrast with 5 ml of contrast, and we check it. If there is no extravasation, we can close the arteriotomy with one per-close device or to use an angiosyl. If we have a mild or moderate extravasation, we can use a second ProGlide. But if there is a severe extravasation, it's better to use a MANTA. Using this algorithm, major vascular complications were less than 1%. In conclusion, I have to say that, as we said before, CT is very useful and a fundamental tool for planning TAVI procedure, especially the vascular access. We have to use echo for having less vascular complications. We have to know to manage vascular complications, and closure devices are essential for hemostasis and TAVI excellent outcomes. Thank you very much.
Thank you, Dr. Kolyviras. Very nice presentation and very informative. Any comments or questions from the panelists or from the audience? Some interventionalists use it for the beginning two ProGlide and one HYGEIA. Do you have any comments about any experience for this?
Yes, but as we showed
not as a bailout. Mm-hmm. For the beginning, use two ProGlide and one HYGEIA.
I think that using the multi-close algorithm, we are safe, because if we use two ProGlides and one angiosyl, I don't know if we make a damage into the vessel or a vessel dissection or an occlusion. We don't have to be, how we say?
So aggressive.
So aggressive, yes, in arteriotomy, and to check everything at the beginning.
Any comment? Please.
Thank you very much for the excellent presentation. Did you try one ProGlide approach without any calcification?
Yes, we have tried, but I don't think that is a safe procedure to use only one ProGlide.
Yes, but it works, to be honestly.
It depends on the large bore sheath. If we use a 14 sheath, yes, but we can close with one ProGlide, yes. But if you use bigger sheaths, yes. 18 French,
for the 14 French sheath, for the transcatheter aortic valves, you know, many of them are working on 14 French sheath. One ProGlide approach is working,
it's safe.
Working, but if there is calcification, posterior or medial or lateral, and the angles of the ProGlide change when you use two ProGlide approach. This is very well published by Gilbert Tank. One is, for example, if the the place of the calcification is very, very important on CT. Sometimes posterior and medial calcification. Then you put the one ProGlide at 11 o'clock and 2 o'clock. And if the lateral calcification, 1 to 3 o'clock, 1 to the opposite side of the 3 o'clock. This is a new concept for two ProGlide approach, but your parallel technique is also very, very important. But in our experience, really, nowadays, in 14 French sheet, a lot of people, operators also in Turkey, are using one ProGlide approach.
With one single arterial access or with
one 14 French sheet, one ProGlide at 12 o'clock position.
Okay.
Okay, thank you. Thank you very much. Yes. Dr. Triantafylou. Micrófono. Aquí.
Just a short comment. Congratulations for the presentation. It was complete. For the algorithm with the MANTA, in order to, if you arrive at the final salvage by MANTA, you must have not forgotten to store the image of the puncture, because you will be based on that. So, okay, you do the echo-guided puncture, but you must store the image of the needle at the point of puncture, because then you must advance 2 centimeters.
This is a very good comment.
Okay.
In our daily practice,
do not forget that.
Yes, we do the same. We use
can
fluoro
save the
and
day.
echo.
It can save the day. And beware of arteries, common femorals, with diameter less than 6 millimeters, because the anchor of the MANTA can cause obstruction. Okay.
Okay.
Just
Thank you. Thank you very much. Thank you.
Thank you very much. So.